Stringent complete response is defined by absence of the monoclonal protein that the patient had at the time of original diagnosis, along with normalization of the free light chain ratio from the time of diagnosis to a certain time in their therapy. Usually we check these responses during the course of induction chemotherapy, along with absence of monoclonal plasma cells on the bone marrow biopsy. And then the light chain assay, which measures the kappa or lambda and lambda light chains, which are also produced by the plasma cells, their ratio has to normalize to declare that the patient has stringent CR. Depth of response is important for all cancers in general. We do recognize that the patients where we can reduce the tumor burden as much as possible, they're the ones who are actually going to benefit the most from that intervention. We know this from the solid tumor clinical trials data spanning over 4 decades, and the same holds true for hematologic malignancies. With myeloma, we've known from the data of the IFM data from the 90s to the late 90s, as well as the Arkansas data, that depth of response, getting to a complete response, matters. Those patients do benefit from therapy. So for the standard and the intermediate risk patients, depth of response is important. Serum protein electrophoresis along with immunofixation, urine protein electrophoresis along with immunofixation, and the Freelite assay are utilized to determine the presence or absence of the monoclonal protein and whether the free light chain ratio has normalized or not. Then a bone marrow biopsy is used as a confirmatory test to make sure that monoclonal plasma cell family is no longer seen on the biopsy. Minimal residual disease testing is complementary to the current response criteria. So it adds another layer of scrutiny to what's really happening in any given patient. We do recognize that not all complete responses are the same. For complete responses, we are only relying on the protein production and our ability to measure that protein production by the myeloma cells, and the visible presence or absence of myeloma cells on a very small piece of bone marrow biopsy or a small portion of aspirate, which we feel may be representative of disease in any given patient. So what minimal residual disease testing allows us to do is to really examine the question of residual disease or whether the myeloma is really present in that given patient or not at a very deep level. Absolutely. I think it's extremely important to determine the depth of response in clinical practice, even though a lot of there is data to support the depth of response is important in survival outcomes, and more data is being generated in prospective trials with novel agents to actually augment that clinical practice. But within the myeloma investigator community, we are certainly checking the stringent CR status once the patient gets to their CR status to assess better depth of response.